This is an outline of the talk, which will start with a little bit of an introduction. We'll go on and talk briefly about neonatal hyperbilirubinemia of the unconjugated type, talking about physiologic and pathologic hyperbilirubinemia, and then go on and talk about cholestatic jaundice with liver disease in the neonate. And we'll go through the approach to a diagnostic algorithm, as well as review the clinical setting and management, and reviewing the multitude of causes for neonatal jaundice with liver disease. So just thought we would introduce the bilirubin molecule. Bilirubin is a byproduct of heme metabolism. Hemoglobin is broken up into heme and globin. Heme then is acted upon by heme oxygenase, becomes biliverdin, which has a yellow pigment, and then biliverdin is reduced by biliverdin reductase to bilirubin, which has a green pigment. Bilirubin clearance and excretion occurs within the liver. The bilirubin dissociates from albumin, by which it's carried around in the plasma, and it is taken up by the hepatocytes. It's then conjugated within the hepatocyte by an enzyme, one of the family of glucuronylyl transferases, UGT1A1, which is the primary one in the hepatocyte, and that catalyzes the conjugation of bilirubin with glucuronic acid, making it conjugated bilirubin and making it water-soluble, and allowing it to be excreted from the hepatocyte through active transport via the canalicular transporters. Some of the bilirubin is then reabsorbed through the intestinal wall in the enterohepatic circulation. Now, I have a cartoon of this here from Georgie Becerra, and we'll come back to this cartoon. I just want to introduce it now later as we review the different defects that can cause cholestasis and liver disease. But in this case, as we said, the bilirubin is taken up by the hepatocyte, conjugated within the hepatocyte, excreted into the bile through active transport, goes through the bile ducts into the intestine, and some of that bilirubin actually makes it back up to the hepatocyte via the enterohepatic circulation. In hyperbilirubinemia, we have a disequilibrium between the rate of production of the bilirubin and the rate of uptake, conjugation, and excretion of the bilirubin. So we're going to first talk about physiologic neonatal hyperbilirubinemia, with which we're all familiar. That occurs because of increased production, decreased clearance, as well as increase in enterohepatic circulation of the bilirubin. Increase in production occurs. As you know, neonates are relatively polycythemic compared to adults. Also, the fetal red blood cell has a shorter lifespan, 90 days as opposed to 120 days. And so there is a 2 to 3 times higher bilirubin production in adults, in children, compared to adults. Bilirubin clearance is also decreased in newborns. So the enzyme UGT1A1, the way that bilirubin is conjugated with the glucuronide, there's a relative deficiency of that enzyme in infants, and it doesn't really reach adult levels until about age 14 weeks. And then there's also an increase in the enterohepatic circulation of the bilirubin, so that more bilirubin is coming back via the intestine into the hepatocyte. In neonatal hyperbilirubinemia, the mean peak bilirubin generally in infants is about 2 to 4 days of age. And the mean peak in Caucasian infants is 7 to 9 milligrams per deciliter. 95th percentile is up to around 13 to 18 milligrams per deciliter. And it is relatively higher in East Asian infants. So they peak later, and they also have a higher bilirubin at their peak. And generally, it resolves within 1 to 2 weeks of birth. And that's why, and I've got it in green, appropriate for bilirubin, persistence of hyperbilirubinemia beyond that time, beyond 2 weeks of age, merits further evaluation. And that's really the message of the talk for us as pediatricians, is that that's really an important take-home message. So when does unconjugated hyperbilirubinemia become pathologic? Well, when there's any increase or change in the steps that we just talked about. So if there's an increased production of bilirubin, as occurs in hemolysis with ABO-RH incompatibility, red blood cell membrane defects such as spherocytosis, as in G6PD, if patients are septic, polycythemia certainly, so if they're more polycythemic than the average newborn, and then if they have a lot of bruising, such as occurs with large cephalahematomas. Also, if there's impaired uptake of the bilirubin into the hepatocyte, as occurs in congestive heart failure, in portosystemic shunts, and certain medications can cause that. And I certainly have been challenged with patients who are presented to me with a high bilirubin who in fact have a portosystemic shunt, and that is not necessarily clinically evident until an evaluation occurs. Also, decreased conjugation. So we said before that there is decreased conjugation relatively in neonates, but then defects in the enzyme, which does the conjugation, in the UGT1A1, can lead to increased bilirubin. So Crigler-Najjar 1, which certainly leads to very high bilirubins and needs to be certainly evaluated for in cases of really high bilirubins, and that persists and needs to be treated actively. And then Crigler-Najjar 2, which is a partial defect, partial deficiency of the enzyme, and so therefore generally can be treated clinically, medically with phenobarbital. And then Jobert's disease. Jobert's is a mutation in the promoter region of the enzyme. 9% of people in the United States are homozygous for that mutation. 42% heterozygous. It is benign. But if coupled with another factor, like G6PD deficiency in neonates, will increase bilirubins to levels that need more therapy. We then come to the increase in enterohepatic circulation, which can cause pathologic unconjugated hyperbilirubinemia. And in breast milk jaundice, although the exact mechanism is not clear, it's felt that there's a component or components in human milk which promote the increased intestinal absorption of bilirubin, and thus increase of bilirubin coming back up into the hepatocyte. And also intestinal obstruction will cause an increase in the enterohepatic circulation. So patients with pyloric stenosis, for instance, or duodenal atresia may present as well with jaundice, though they will have other problems as well, like throwing up. Well, what are the risk factors for severe hyperbilirubinemia in the full-term infant? And that certainly needs to be known as we consider therapy for them, particularly phototherapy. So there are some major risk factors. The pre-discharge bilirubin being in the high-risk zone on the nomogram, and I'll show you the nomogram in a moment. Jaundice within the first 24 hours of life. A known hemolytic problem, so nothing new, all the things that we've already talked about. Gestational age of 35 to 36 weeks. So if we consider babies, the nomogram has been created for babies above 35 weeks gestation, and so the younger the gestational age, the higher risk for hyperbilirubinemia. A previous sibling receiving phototherapy, so in other words, a previous sibling who had severe hyperbilirubinemia is a risk factor for the next sibling having it. Of course, as we discussed, cephalohematoma. Exclusive breastfeeding, especially babies who are having difficulties with breastfeeding and are somewhat dehydrated. And as we mentioned, babies of the East Asian race are at a risk for having higher bilirubins and later peaks of bilirubin. So we have here the nomogram. This is a nomogram to designate risk based on our specific bilirubin levels. And so as you can see, as postnatal age increases, there is an increase of the bilirubin, peaking out here at 4 days of age and sort of staying level. And these babies are considered to be in a high-risk zone, so they need extra observation. These in a lower risk zone needing less observation and perhaps no follow-up necessarily for that bilirubin increase. So what do we do about pathologic neonatal hyperbilirubinemia? Well, how do we prevent it? Well, we do want to promote breastfeeding. I had mentioned that breastfeeding is a risk factor, but that's breastfeeding where the baby starts getting dehydrated. And so we certainly want to promote breastfeeding and hydrating, supplementation when necessary. And of course, then there's the universal testing of the bilirubin. And I'll show you in a moment the algorithm that was published in Pediatrics early in 2000, I think 2004, that has an algorithm to try to get us to prevent the occurrence of pathologic hyperbilirubinemia. And then treating it, once we know that somebody has it, phototherapy, exchange transfusions, and again, promoting hydration, nursing, and feeding. And so here we have the guidelines for phototherapy that were published in that Pediatrics article by the Subcommittee on Hyperbilirubinemia, yes, indeed, in 2004. And these are the guidelines for phototherapy for babies who are 35 or more weeks gestation. And as you can see, babies who are at a lower risk can have a higher bilirubin, but at the initiation of phototherapy, because they don't have additional risk factors to the number, whereas babies down here who are at a higher risk, so they are of younger gestation and they have other risk factors, should be treated, consideration for treatment should be made earlier on at a lower bilirubin. These are just guidelines. They're based on limited evidence, and the levels that are shown are approximations. But it is really helpful when you have a given bilirubin on a patient to plot them here and see where do they fall, what are their risk factors, and should you, and give at least a rational approach to the initiation of phototherapy. So we've been talking about pathologic hyperbilirubinemia. What are we worried about? As you know, we're worried about acute bilirubin encephalopathy and then the ultimate chronic bilirubin encephalopathy, kernicterus. We sometimes use kernicterus now to include all of this, but truly kernicterus is more the chronic manifestations. So bilirubin can be deposited in brain tissue. Neurologic injury then occurs secondary to that bilirubin, and the early manifestations we see acutely is lethargy, hypotonia, and poor feeding, and that can progress to stupor and seizures. And in the chronic changes that we see with the bilirubin being deposited in the basal ganglia is athetoid cerebral palsy, hearing loss, visual problems, and mental retardation. So that's what we're trying to avoid. And here's the algorithm. I don't think you can see it, and it's not meant to be read, but it's worthwhile taking a look at. But it just focuses us on the management of jaundice in the newborn nursery, ultimately coming to where they're still jaundiced at 2 to 3 weeks of age, and that's when we start worrying about conjugated hyperbilirubinemia as being a possible etiology and needs to start getting looked at. So we're going to switch gears and go now to conjugated hyperbilirubinemia from unconjugated hyperbilirubinemia. And in conjugated hyperbilirubinemia is felt generally to be caused by at least some component of liver disease. And when we have that, we think of the baby as having cholestasis, so the bile is sort of stuck. What's the definition? And somewhat it's a little bit of splitting hairs, but when we're asked to consult on this, it really does become important as you get to the higher bilirubins. So when the serum bili is less than 5, it's easy. The conjugated bilirubin of more than 1 is considered to be abnormal. But if the bilirubin is greater than 5, it's felt that a conjugated bilirubin of greater than 20% of the total bilirubin is considered to be abnormal. So as we said before, and again, I'm going to repeat this a few times because I think it's the most important message, that most physiologic jaundice resolves by 2 weeks of age. There's a good percentage of newborns, though, that are still jaundiced, even at 2 weeks of age. And that's why, if they're still jaundiced at that point, the recommendation is somewhere between 2 to 3 weeks of age that a total and a direct bilirubin should be measured. For babies who are formula fed, generally 2 weeks is used as a measure. Because of breast milk jaundice, some people would stretch that out to 3 weeks for breastfed babies who don't have any other issues that are readily seen. So this is the differential diagnosis for neonatal cholestasis. Again, not meant to be seen. The point being that the differential is very long and complex, and we need to have some rational approach to the diagnosis of what the cause of neonatal cholestasis is. So what are the causes of cholestasis? Well, our view of that has changed from when I was a first-year fellow, not in 1970, after that. But it's changed from this big purple unknown, which we call idiopathic neonatal hepatitis, to a more spread out etiology where most of the causes now of idiopathic neonatal hepatitis have been identified. Biliary Atresia, which is responsible for about 25% of cholestasis, has remained the same over the years, still 25% when it was last looked at. And 10% here is alpha-1 antitrypsin deficiency, still remains 10%, and the infectious etiology still remains about 5%. What's changed is this particularly is this category here, which are the intrahepatic cholestatic syndromes that we are going to talk about. So in terms of a diagnostic approach, as I said, that was a very long list. They got categorized a little bit more easier in the last slide. But what we want to do is we have to go back to our basic pediatrics and try to do a clinical evaluation. Unfortunately, there may be absolutely nothing extraordinary in the basics of the history, family history, past medical history in a neonate, and the physical exam. On the other hand, we do go through it. The sicker the infant is, the more likely it is to be a metabolic cause early on. We look at the stool color. Acolic stools tends to be more associated with an actual blockage of bile coming out of the liver. But there really isn't that much other than jaundice that's going to lead us to figuring out what the cause is. And so then comes the laboratory evaluation. As we mentioned before, the fractionated serum bilirubin is key. If that's elevated, then it's cholestatic, and we need to pursue the rest of the workup. So tests of hepatocellular and biliary disease, look at the ALT and the AST, of course, the transaminases, and then we look for biliary disease, evidence of biliary inflammation, alkaline phosphatase, and then the GGTP, the gamma-glutamyl transpeptidase. And that's important because there is some specific intrahepatic cholestatic syndromes which are associated with low GGTPs or normal GGTPs rather than elevated ones. And then tests of hepatic function. Remember, these are not the ALT, AST, and the ALK-Phos are not liver function tests per se. To test function, whether the liver is failing, we have to look at the albumin, the coagulation measurements, whether they're hypoglycemic, and look at their ammonia level. So our diagnostic approach is generally staged, and the first thing we want to do is exclude treatable disorders and any medical emergencies. So sepsis certainly could cause hyperbilirubinemia, so bacterial cultures of blood and urine, because urosepsis certainly can present early on as hyperbilirubinemia. Baby is generally sick, but we do have to remember that some of the cause may be an intrahepatic one. Panhypopituitarism also can present with cholestasis, and again, the sort of basic measurements of serum electrolytes, glucose, thyroid hormone will lead us that way. Galactosemia can present easily as sepsis, and so looking for that, and we'll talk for galactosemia, and we'll talk about the test for that, as well as for tyrosinemia, are important early on because these are eminently treatable, and so therefore need to be found earlier rather than later. And then, and again, this is one of the take-home messages, we have to exclude biliary atresia and other extrahepatic disorders. And that's key because those are treatable and need to be treated early in order to avoid the manifestations of chronic liver disease early on. In order to do so, imaging studies are important. We start with ultrasonography generally, and that will lead us to rule out cysts of the bile duct, as well as then a HIDA scan, and we'll talk about that in more detail when we talk about biliary atresia. So now I'm going to go through the rest of the diagnostic approach to neonatal cholestasis. And again, it needs to be staged. We talked already about ultrasonography and HIDA scan, and so in relation to biliary atresia and other extrahepatic disorders. Infectious etiologies, as we saw, they're responsible for 5% of neonatal cholestasis. Toxoplasmosis, rubella, cytomegalovirus, herpes, syphilis, and HIV. And these are usually not subtle. You know, in rubella, the blueberry muffin baby, cytomegalovirus, certainly the implications of a baby who has CMV hepatitis are not good. And then metabolic, that very large category that we saw. So we talked about galactosemia before. Generally, that can be ruled out with the newborn screen. But if you have the child in front of you and the newborn screen's not ready, urine-reducing substance can easily be done. I have never forgotten when I was an intern that little Clinitest turning from blue to green. We generally don't do those anymore at the bedside, and we now do them in CLIA-approved labs, but it is very telling sending that. Urine bile acid should be sent to look for bile acid synthetic disorders. That does not come back very quickly. Serum amino acids, looking specifically for citrin deficiency. Urine organic acid, succinyl acetone, looking for tyrosinemia, which again is eminently treatable. And alpha-1 antitrypsin, looking at specifically at the phenotype. And we're going to actually review each of these a little bit more in detail as we move on. Then going on to genetic testing, sweat chloride for cystic fibrosis, chromosome analysis. Again, the chromosome analysis certainly doesn't have to be done early on right away, but we know a lot more now than we did 20, 30 years ago, and so we can certainly define the cause of the cholestasis much more easily these days. And then specific genetic testing, and we'll talk about these as we move on through the talk. And then hematologic evaluation, Coombs testing, reticulocyte counts, are they hemolyzing, and a ferritin level looking for what we used to call hemochromatosis, but it really is a nonspecific measurement of liver inflammation. So let's go to the clinical now. What are the clinical? We've talked about cholestasis and the causes of it. The clinical consequence of cholestasis is that is really across most of the intrahepatic cholestatic syndromes is really pretty much the same. There's diminished bile flow, and that results in retention of the bile. So the retention of bile acids causes pruritus and hepatotoxicity. And that may not be evident early on in the neonatal period, but becomes evident as time goes on. Bilirubin obviously causes jaundice, and that's the most obvious thing we see. And along with that, as the bile doesn't pass through easily, cholesterol is retained, and there's hypercholesterolemia, and ultimately you may see xanthomatosis. And again, this may not be evident in the early neonates. The reduction of bile acid delivery to the intestine results very importantly in malabsorption of fats specifically, and so you get a child who has failure to thrive and malnutrition. You get deficiencies of the fat-soluble vitamins A, D, E, and K, and their attendant problems, and progressive liver disease ultimately, with portal hypertension and ultimately with liver failure. And a lot of that doesn't occur necessarily in the early neonatal period, but the wheels are put in motion early on. So how do we manage cholestasis? Well, ursodeoxycholic acid basically is ubiquitous management for almost all the causes of cholestasis. And it's felt to improve bile flow, and it also is thought to protect the hepatocytes as well as the cholangiocytes. It's a hydrophilic bile acid, and really is any child who's got cholestasis, we generally will start on ursodeoxycholic acid. And then there's the management of the pruritus. Again, ursodeoxycholic acid works somewhat for the management of the pruritus, but when that's not working enough, go to rifampin, cholestyramine to sequester the bile acids, and naltrexone has been shown as well to help with pruritus. The other thing that we do is we can interrupt the enterohepatic circulation. So the bilirubin that comes into the, that makes it into the intestine, again, we want to try to send most of it out as opposed to allowing it to be reabsorbed in the intestine back up into the hepatocyte. And so that there's surgical biliary diversion and there's medical biliary diversion. That's the medical biliary diversion is a relatively new concept. There are some medications that are in development which have been tried in hypercholesterolemia, and they're, I don't think, going to be used anymore for that, but they do inhibit ileal bile acid transporter, and so theoretically they should be a really important addition to the management of children with intrahepatic cholestasis. And then the nutritional management. We have to manage the malnutrition and the risk of failing to thrive by increasing the calories, supplementing with medium-chain triglyceride-containing formulas, which are much more easily absorbed, and then, of course, vitamin supplementation with the fat-soluble vitamins, A, D, E, and K, preferably in aqueous forms and in high doses. So we're now going to get into some of the specific entities. The first sort of entity we're going to talk about is to try to separate the extrahepatic causes of neonatal cholestasis from the intrahepatic causes. Because the extrahepatic, which are associated with obstruction to bile flow and anatomic obstruction to bile flow, are generally treatable in some way and should be treated early on. And these are some of the extrahepatic causes, the most common ones. Biliary atresia. As you saw before, biliary atresia is responsible for 25% of neonatal cholestasis. And then lesser known causes, bile duct stricture, choledochal cysts, intrahepatic as well as extrahepatic cysts, inspissated bile syndrome, masses in the liver or obstructing the gallbladder or obstructing the bile ducts, neonatal sclerosing cholangitis, gallstones. And then there's a fairly uncommon, but a board question nonetheless, spontaneous perforation of the bile duct and other anomalies of the pancreatico-duodenal junction, which all can cause extrahepatic obstruction and cause neonatal cholestasis. So we're going to go into biliary atresia, and that's the one entity I'm going to go into in more detail than the rest. Again, trying to bring home the importance of measuring that direct bilirubin early on so the evaluation for this can be planned. So what is biliary atresia? It's idiopathic, it's progressive, and it's destructive. And it causes fibrosclerosing of the bile ducts and results ultimately in complete obliteration of the hepatic or common bile duct lumen, generally by 3 months of age. It's the most common cause of chronic cholestasis, as we saw before, 25% of cholestasis. Most common indication for liver transplantation in pediatrics. The incidence is somewhere between 1 in 8,000 to 1 in 15,000. And it's non-Mendelian inheritance, possible seasonal clustering, though not clear, and a slight female predominance of 1.2 to 1. There are two forms of biliary atresia. There's the embryonic form and there's the perinatal form. The embryonic form, generally, the onset of cholestasis is early. It's responsible for a smaller percentage than the perinatal one. It's associated with congenital anomalies, particularly congenital anomalies related to laterality. There is no jaundice-free period between physiologic jaundice and this because it is embryonic and it occurs early on. And in the perinatal, it's very common to hear a story, the baby was jaundiced early on, that went away, and then somewhere around 3 to 4 weeks, jaundice reappeared. What are the clinical features? Again, jaundice is the main clinical feature, and it's a conjugated hyperbilirubinemia. And as I mentioned before, acholic stools. So the stools without any pigment because there's no bilirubin coming through. Most of these, the hepatosplenomegaly, failure to thrive, pruritus, and coagulopathy occur later. Most babies who present somewhere between 4 to 6 weeks of age with biliary atresia are presenting looking well. They generally were born at term. You're not going to find anything specific to say, oh, this is biliary atresia generally. What are the laboratory features? Again, nonspecific. The bilirubin will be elevated. 50% of it or so will be conjugated. The rest will be unconjugated. Alkaline phosphatase and GGTP are moderately to markedly elevated, again, because it's primarily a disease occurring at the bile duct level. The AST and the ALT, in terms of hepatocytes inflammation, are mildly elevated, and generally synthetic function is normal at first. Abdominal ultrasound is done first when you see a patient with cholestasis, as we talked about, aside from the laboratory evaluation, and that's to exclude a choledochal cyst. Most infants with biliary atresia do not have a gallbladder, but that is not perfectly sensitive or specific. And so lack of a gallbladder does not mean it's absolutely true to be biliary atresia, and certainly having a gallbladder also does not mean that the child does not have biliary atresia. And polysplenia, situs inversus, and abnormalities of the vasculature, particularly of the hemiazygous vein and the inferior vena cava, are not infrequently seen with the embryonic form of biliary atresia. Scintigraphy is generally the next step that we do. We try to pre-treat with phenobarbital, especially with the higher bilies, and when that's all done, it's pretty sensitive, 95% sensitivity, because of other entities showing lack of uptake in the liver and other intrahepatic cholestatic syndromes. It's not perfectly specific for biliary atresia. So this is a picture of a scintigraphy here. This is a normal one. As you can see here, here's the liver lighting up, and then you can see the gallbladder here, and then here's this excretion of the label into the small bowel, and then you see the bladder lighting up as well, and the bladder actually lights up fairly early. This is an abnormal scintigraphy where you see uptake in the liver. You can see it in the bladder, but there's nothing being seen in the intestine. Now, you would think that in 2014 that there would be other imaging available that can non-invasively test for biliary atresia. So MRCP, which has become a good way to study the biliary system. Unfortunately, in neonates, anesthesia is required, and it may not adequately differentiate other forms of obstruction. And then ERCP is not so invasive. It's technically very challenging in small infants, and it still remains invasive, and again, needing anesthesia. However, in certain hands where this is really practiced well, it can be particularly helpful in ruling out a biliary atresia. So liver biopsy is really where we end up making the diagnosis, the accurate diagnosis, or at least the initial diagnosis before trying to the intraoperative diagnosis. The accurate diagnosis occurs in 95% of patients by liver biopsy. The early findings we have, and we'll see that on the next slide, is a general preservation of the basic architecture. There's bile duct proliferation is seen. There's bile stasis and portal edema and fibrosis. So here you can see the bile stasis, the orange staining of the liver, and you have the bile duct proliferation here, these little ring-like structures as well. And then later on, there's portal fibrosis with wide swaths of connective tissue. We'll see that in the next slide, extending into the liver substance. And there's portal inflammatory infiltration with giant cell transformation in some infants, which is indistinguishable from neonatal hepatitis and indistinguishable from some of the intrahepatic cholestatic syndromes. And this is the blue is the collagen that's being put down and the fibrosis that's being seen. And basically you have a cirrhotic type of picture here. The ultimate diagnosis depends on surgical exploration. And so intraoperatively, a cholangiogram is done to check the patency into the liver and into the bowel and see that they're connected indeed. Frozen sections of the porta hepatis are done to see if there is a patent bile duct and see how small it is. And then ultimately, the surgical procedure that's done to relieve the atresia is a Kasai hepatoportoenterostomy. Kasai is after the Japanese physician who founded this procedure, and it's a Roux-en-Y loop of bowel that's anastomosed up to the liver hilum. So again, the take-home message here. What determines success of Kasai is how early the Kasai is done. And again, that's why we need to be ever vigilant of knowing that we're dealing with a direct hyperbilirubinemia rather than an extension of physiologic jaundice. So if the age at Kasai is less than about 2 months of age, the success at clearance of the jaundice is about 75% or so. If you go beyond that, it becomes much less successful. But even when we clear the jaundice, the ultimate, initially, the ultimate outcome may not be so sanguine. So here we see some data on the need for transplantation by age 4. In babies who have had Kasai at less than 30 days of age, 50% of them exist with their native liver by age 4. If the Kasai is done between after 30 days of age, after 1 month of age, 36% of those have their native liver, which means that 64% or so have been transplanted or have died. So it turns out that 60 to 80% of patients with biliary atresia in the Western world, as far out as this has been studied, will ultimately require a transplant. And when is a transplant evaluation needed? When the Kasai primarily fails and there's no drainage, when growth failure is refractory, the complications of portal hypertension, progressive liver dysfunction, and recurrent cholangitis. And I'm not going to go into details on any of that today, as the discussion is really more focusing on neonatal hepatitis. And again, here's a long-term outcome after Kasai survival with the native liver. This is to show differences. Japan has much better outcomes than the rest of the Western world. At 5 years after the Kasai, in Japan, 63% still have their native liver, 38% in France. And we don't have comparative groups here, but if we go out 20 years in Japan, 44% still have their native liver. And yet, in the study that was done in France, spanning the years of patients having Kasais from 1986 to 2002, about 30% still have their native liver. So that's the problem with the delayed diagnosis. Back in the 90s, in the United Kingdom, greater than 50% of children were being referred after 6 weeks of age, and so they started a yellow alert education program where serum total and conjugated bilirubin was done for infants who remain jaundiced beyond 2 weeks of age. Some of the success in Japan and Taiwan of finding children earlier are these stool color cards that are given to mothers of newborns. And so mothers are sent home with these, actually fathers could be sent home with them too. So parents are sent home with these cards and are supposed to send them in to denote what color the stool is, and if the stool color is in this area, then they are brought in earlier rather than later to check them out. So I'm going to come back to this slide again because we've looked at this group, 25% of kids with biliary atresia. The next thing we're going to do is take this next large group of 25%, which includes babies who have intrahepatic cholestasis due to Pfix, and we'll talk about that, Allergies and bile acid storage disorders, the intrahepatic cholestatic disorders. So the Pfix syndromes, that's familial intrahepatic cholestatic syndromes, are due to different enzyme deficiencies, and we're going to discuss those. And this is the bile acid storage disorder that is known to cause intrahepatic cholestasis. So persistent familial intrahepatic cholestasis are a family of chronic cholestatic disorders which begin in infancy. It's been over only the last 20 years or so that they've been recognized. They can be rapidly progressive within the first decade of life. There are now known 3 subtypes, and the specific gene defects for them are known. And the problem is in the export from the liver cell. Pfix 1 and 2 have a defect in the gene product that's required for the canalicular bile acid export and bilirubin formation. And Pfix 3, there's a defect in the phospholipid export out of the hepatocytes. And the treatment, though, is the same as we talked about before for intrahepatic cholestasis, ursodeoxycholic acid to promote bile flow, and treating the pruritus, which can be quite serious. Again, medical treatment of pruritus with known antipruritic agents like rifampin, diphenhydramine, naltrexone, and cholestyramine, and surgical. And I just want to show a picture of the how that's done to interrupt the enterohepatic circulation. This is a picture of an internal biliary diversion procedure. The other thing that's done is an external biliary diversion procedure, but essentially a loop of intestine is inserted into the gallbladder and brought out into the colon or brought out into the abdominal wall to divert a good amount of the bilirubin to be excreted, and so that it won't undergo enterohepatic circulation back up into the liver. And that really works very well as an antipruritic exercise. So these are the 3 Pfix that are known. These are the genetic defects, the different genetic genes that are affected in each of them. Pfix 1 is also known as Biler's disease. These are the chromosomes on which those genes are, and this is the actual protein that's affected in each of them. In Pfix 1, as we said before, that enzyme causes increased phospholipid membrane instability and therefore causes a decrease in the ability for bile acids to be transported out of the hepatocyte through those through the canalicular membrane. The bile salt export protein causes mutation there's a mutation in that protein and in that pump, and it leads to cholestasis. And then with multi-drug resistant 3 deficiency, you have decreased phospholipid concentration in the bile, which leads to destabilization of the micelles, inflammation, and cholestasis. Other features which distinguish the 3 of them are extrahepatic manifestations in Pfix 1, because the same mutation can also be found on the intestine, and so diarrhea may be seen because there's decreased bile acid transport, and so there's a bile acid diarrhea, as well as pancreatitis. I'm sorry that the slides, I don't know if you can see the slides, but the bottom got cut off. But in Pfix 2, there's a risk of hepatocellular carcinoma and cholangiocarcinoma. And in Pfix 3, that is a less severe form of Pfix. Only about 1/3 of those present during infancy and the rest during childhood. And there are other diseases as infants get older, even into adulthood, that are part of the spectrum of deficiencies of these enzymes. MDR3, in fact, a deficiency of that has been related to intrahepatic, into cholestasis of pregnancy. The important thing here is that Pfix1 and Pfix2 are distinguished by their low GGT levels. So normally we think of bilirubin problems and the excretion of bilirubin problems associated with a high GGTP, but because the bile acid isn't getting exported, the GGTP isn't getting released in the biliary system, and so these are distinguished by low GGTP. So when the initial laboratory evaluation is done on these babies and you see a low GGTP level in a child with neonatal cholestasis, these two really need to come to the forefront. It is unlikely to be biliary atresia. It's unlikely to be any of the other diseases associated with it, except for the next one that we're going to talk about, which is the bile acid synthesis defect. So again, this has recently being the last 20 years, been discovered. There are specific enzyme defects. The 3-beta-hydroxysteroid dehydrogenase deficiency was, I believe, the first one that was found, and there are other ones now which have been described. As a result of these deficiencies, atypical bile acids are formed, and those atypical bile acids are toxic to the liver. Because they are atypical, they don't get released into the biliary system, and so again, there's a low GGTP here. And so because of these bile acids don't get released, and they're atypical bile acids, there is no pruritus associated with it. And so that also distinguishes this set of defects from the other defects causing intrahepatic cholestasis. The diagnosis is made by fast acid bombardment of the urine for analysis of bile acids. And they're eminently treatable generally with oral bile acid therapy if started early, so before too much damage can occur from the atypical bile acids. Ursodeoxycholic acid has been used, and more recently, other bile acids, cholic acid, have been shown to be even more effective for the management of the synthesis defect. And so now we're coming to the third of the intrahepatic cholestatic syndromes, Allergies Syndrome, which is part of that 25% that we saw before, causing cholestasis. Allergies Syndrome is a paucity of the intrahepatic bile ducts that causes chronic cholestasis. There are associated clinical extrahepatic features that we see, cardiac anomalies in about 80% of babies, butterfly vertebrae, again in over 80%, posterior embryotoxin of the eye in almost 90% of babies is seen, and a dysmorphic facies with a triangular face and a beaked nose, which is not clear is related just to intrahepatic cholestasis in general or to this specific lesion, Allergies syndrome. And also renal dysplasia has been described in these babies as well, up to about 70%. More recently, we've noted that brain vascular malformations can be noted, leading to stroke, as well as pancreatic insufficiency, which can perpetuate the poor growth in some of these babies. The incidence of these in Allergies is really not known. Allergies is an autosomal dominant disease with variable penetrance. JAG1 gene defect is now seen in greater than 90% of patients, and some other patients have been noted to have a Notch2 defect. Basically, these proteins that these genes code for are important in cell signaling and resulting in errors of development of the bile ducts. The diagnosis generally is made initially by liver biopsy showing ductopenia, along with some of these other clinical features. And ductopenia, sometimes on liver biopsy, can be challenging to see, particularly because if you don't have enough bile duct portal tracts, you may have ductopenia just because you just don't have a large enough sampling. So generally, you need to have a good sampling of portal tracts to really diagnose the ductopenia. The management is pretty much the same again as we talked about before. Promote bile flow with ursodeoxycholic acid, treat pruritus, which can be quite significant, aggressive management of the growth failure with high-energy supplements, fat-soluble vitamin supplementation, and as we mentioned before, they may have pancreatic insufficiency, so they may need to be evaluated for that. And then managing the cardiac and the renal disease are really important, obviously, in those children who have significant cardiac and renal problems. End-stage liver disease occurs in about 20% of these. Frequently during the first decade of life, the cholestasis, the hyperbilirubinemia recedes, and the children and then adults are left with chronic liver disease that they end up living with. And the management really focuses in on making sure that they are gaining weight appropriately and that they are not pruritic, as well as hypercholesterolemia is a significant finding in a lot of these children. So we're coming back again to our cholestasis spectrum. So we've now covered the biliary atresia, we've covered the intrahepatic cholestatic syndromes, and the next large group are those thrown into the metabolic. And as we get smarter and learn more about gene defects and enzyme defects and protein defects, we cut back that category of neonatal, idiopathic neonatal hepatitis and add generally to this category of metabolic disorders. These often present with liver failure as opposed to the ones that we've talked about before, which generally don't present with liver failure. Galactosemia, as we mentioned before, can present with urosepsis or sepsis in the first week of life, generally after feedings are started. Deficiency of galactose-1 uridyl transferase, and is eminently treatable with a lactose-free formula. Hereditary tyrosinemia, there's a deficient enzyme in the fumarole acetoacetate hydrolase enzyme. Again, presents frequently when it presents with cholestasis and coagulopathy, indicating liver failure. There is a risk of hepatocellular carcinoma with these babies, so you need to check their alpha-fetoprotein levels. And even when they get treated with nitisinone, nitisinone is a protein inhibitor of this enzyme that reduces the formation of the toxic metabolites that are associated with tyrosinemia and really makes tyrosinemia potentially treatable, again, if started early. However, even treatment with that will not decrease the risk of hepatocellular carcinoma, so checking AFP levels on an ongoing basis is still important in those babies and as they become adults. There's the whole category of lipid metabolism disorders, and many of these are associated with neurologic abnormalities, and the neurologic abnormalities are very evident fairly early on. Lysosomal acid lipase deficiency, otherwise known as Wolman's disease, generally presents with hepatosplenomegaly, fibrosis, adrenal calcification and insufficiency, malabsorption, poor weight gain, and generally is fatal in infancy. There's a spectrum of lysosomal acid lipase deficiency, and children can present later on in life with that as well. Niemann-Pick disease, which is a deficiency of acid sphingomyelinase, and that causes a defect in cellular cholesterol esterification. There's a disproportionate splenomegaly in those babies with the storage of the lipid and developmental delay in those babies as well. And then Zellweger syndrome, hepatocerebrorenal syndrome, which again, reduction, they present with multiple system failures, neurologic abnormalities. It's an autosomal recessive inheritance. There is a spectrum as well with adrenoleukodystrophy and Refsum disease. One of the way the diagnosis can be made is looking for very long-chain fatty acids, which are not degraded and generally fatal by 1 year of age. And I'm not going to go through the details, but the mitochondrial DNA depletion syndromes, also again presenting frequently with neurologic problems and with what appears to be liver failure, and citrin deficiency, which is neonatal onset citrullinemia. And that can present really more, so it's only been seen in the neonate in Asian infants, and those symptoms remit with fat-soluble vitamin supplementation and lactose-free formula or MCT-containing formulas. And so that's, although very uncommon, is worth thinking about, and can be found in the by looking for amino acids in the serum and urine, because it is generally treatable. So again, back to the slide, we've taken care of that category. We've taken care of this category of the intrahepatic cholestasis, the metabolic syndromes, and so now we're going to go into alpha-1 antitrypsin deficiency and mention the neonatal hepatiditis. Alpha-1 antitrypsin deficiency, alpha-1 antitrypsin is a protease inhibitor. It's inherited via an autosomal codominant transmission. The normal allele is the M allele, and the most common mutation leading to deficiency is the ZZ phenotype. Only 10% of babies of that phenotype have liver disease, in a very well-known Scandinavian study done back in the 80s. There's an accumulation of an abnormal protein within the endoplasmic reticulum that results in injury of the hepatocyte and results in cholestasis. Generally not treatable, except ultimately with liver transplantation for those babies who meet the criteria for needing a liver transplant. Generally not in, and I said for babies, generally it's as they get older. So generally it's more in the child and the adolescent. Cystic fibrosis, we shouldn't forget that. Neonatal cholestasis is an uncommon presentation of cystic fibrosis. About 5% of neonates with CF are found to have neonatal cholestasis, and the CFTR. And why is that? The CFTR is found on the biliary epithelium as it is on other major epitheliums. So it is something that we need to think about, and why we think about doing sweat tests in babies with cholestasis. And this is a summary, basically, going back to that cartoon of Georgie Becerra's. But here we have the hepatocyte and the biliary system, and it summarizes a lot of the defects and lesions, the ones in the canalicular proteins causing the familial intrahepatic cholestatic syndromes, the bile acid storage disease, which is a mutant enzyme in the hepatocyte. FIC1 also can be found on the biliary cells, CFTR from cystic fibrosis, JAG1 from Allergies Syndrome, and then the mutant alpha-1 antitrypsin caused by alpha-1 antitrypsin deficiency, causing an abnormal protein in the hepatocyte, which results, and all of them resulting in deficiencies and defects in transport either through the hepatocyte into the biliary system or through the biliary system into the intestine. And finally, a word about gestational alloimmune liver disease, also known as neonatal hemochromatosis, GALD. And for years, this was called neonatal hemochromatosis, although it was very different and known to be very different than adult onset hemochromatosis. And it was called that because of the iron deposition that was noted in the liver and other organs. It is recognized now that that is really a nonspecific finding due to hepatic failure. GALD has an intrauterine onset. Signs of liver failure and hyperbilirubinemia are noted right away at birth with coagulopathy, hypoalbuminemia, and ascites. And the etiology was noted by Whittington to be reactive immunoglobulin G from the mother, which activates the complement cascade in the infant with subsequent fetal liver injury. You can stain for the terminal complement cascade with an anti-human C5b9 complex, and it is pathognomonic for this lesion. And treatment now has become much more effective. We really did not have an effective treatment for this before, except for liver transplantation, and many children and infants died with this. But now intravenous immunoglobulin and exchange transfusion have become the standard of care, and very effective, over 80% effective. Gestational therapy for subsequent pregnancies has become also the standard of care, so that because this is an alloimmune disease, subsequent pregnancies are at a high risk for developing the same problem, about 90% in subsequent pregnancies, and treating the mother during her pregnancy with IVIG is very effective in preventing the manifestations of GALD. And finally, I'm going to come back to that little category, the idiopathic neonatal hepatitis, which keeps shrinking over the years. And basically, that's prolonged conjugated hyperbilirubinemia without any obvious etiology. And as we continue to identify specific disorders, the incidence of this has declined and likely will continue to do so. And so to summarize, neonatal cholestasis is a complex group of diseases, all of which present at least in part with jaundice, some of them with other problems as well. The incidence of each individually is small. As a group, the incidence is much more frequent. It's important for us to stage the diagnostic evaluation, because if we attacked everything all at once, we wouldn't be able to get through the list, and we would not have necessarily useful information. And so, again, we have to perform a fractionated bilirubin for jaundice lasting more than 2 to 3 weeks. Biliary atresia and some of the other diseases we talked about need to be differentiated early on so that the most effective treatment can be given. And the treatment for the cholestasis is pretty much similar for most of the entities we've talked about. Ursodeoxycholic acid to promote the bile flow, nutritional support to provide adequate calories and adequate fat-soluble vitamins for growth and to minimize fat-soluble vitamin deficiency. Management of the pruritus, the itching, either medically through antipruritic management, trying to sequester the bile acids, and using the ursodeoxycholic acid, and then the surgical biliary diversion, which we noted before. And then ultimately, if all of that doesn't work and things continue to deteriorate, liver transplantation. And this is just to end with a picture of this baby who had a Kasai procedure. As you can see the, and who ultimately had a transplantation, and is a very happy-looking baby there. So that's where we want to go. So remember, early measurements of fractionated bilirubin.